And now I'll get Tufail going about what he does with tough clots. So we are passing over from regular clot to a tough clot, and then we go on to ICAD, which Matthew has mentioned. We see quite a few of ICAD in our country as well. Yeah, Tufail.
I'm still not convinced about MR, and I hope by end of the day somebody convinces me about MR. I'll leave it to Matthew. Okay. You've seen different approaches. I use double stent as my first pass. So I don't even piss around with trying to do aspiration. And one of the reasons is that you kind of are trying, first pass, second pass, third pass. Why not just go to the most difficult approach? And I don't think it is really a difficult approach at all. Double stent retriever was described around 2017, and you can see the outcome was significantly, seems to be better than doing it with a single stent or aspiration at that time. We're discussing only the technical side today. So how do I do it? Usually I have a balloon guide catheter here, and then this is what I do. I have two stents parallel to each other, one going into one M1, M2, second going into the other one. If it's in the basilar, I go on both sides, and then I will bring the stents together. You can do it, and yesterday Matthew mentioned he did cases where he has put 3 stents, and you can have obviously parallel stents. You can have one stent, 2 stents. You can have 3 stents. You can have 1 stent here, and then you can bring all together. But generally, what I do is the technique which is here. I have 1 stent here, 1 stent in the other one. How do I do it? And I think for me, it allows you to trap the clot much better, particularly in refractory clot. It removes any need for intermediate catheter. So I have no intermediate catheter, and you don't need distal aspiration, and you potentially, when you're aspirating, you can collapse the vessel sometimes, and you may not get the clot. All that is pretty much out of the window if you're using 2 stents. Of course, there is a risk when you're pulling 2 stents. You can cause damage, and you have to be very careful, and I'll show you a case in the end. If you're not very careful, you can get into trouble. Then this is some of the data which Mark Ribot has published, and you can see between the first pass recanalization is what we are looking at. You have a significantly better outcome in terms of success outcome, in terms of between double stent retriever and single stent retriever, and you can see the difference here. So let's show you the first case. This is a 59-year-old man with hemiplegia, and like I said, in UK, pretty much CT is a main line. We don't do MRs in stroke at all. Also, technically, it's always difficult because MR is in a different part of the building. So I think time becomes an answer. So we have always done CT. So his NIHS is 17. You can see he's come in for a thrombectomy. As you can see, the CT doesn't look very bad here. You might have some ischemia around here. You can see that there is a M1 clot that you can see. And then look, in most of these patients, you will see the arches are, and in Indian patients, the vessels are much worse. Aspects of 5-6, right M1 occlusion, gets a thrombolysis, comes across, and this was done under local anesthetic. As you can see, you got a catheter here, and then you put 2 stents in. My approach now, I have changed from flow gate to walrus, more or less. If I get a walrus, I think walrus is I don't know whether it's available in India, but I think it's a much better aspiration catheter. But flow gate does the job too. The aim is to get 2 microcatheters across, and then I use a 6, and I can use a combination of different. I use a 6 and 4, but it depends on if it's a smaller vessel, I'll go for a 6, for a 440, and a bigger one, I'll put a 640. But I have used 2 6 also. And then you aspirate under balloon inflation. So here you can see you got a balloon right here, And then you have, most important thing is you get into the one branch. So you can see you got one branch and you can see this another catheter. Don't remove your wire from the first catheter. That is very important, because if you remove the wire, then you lose the track of that branch. So you keep the wire in the first microcatheter, go into the other branch, and then you should be able to know that you are getting into two separate branches. So here you can see you have and then once you got one stent here, other stent is here, you got a balloon inflation in this place, and you can have the balloon in as far as you can get, and then you can have a single pass, and you can see you can remove everything together. Here you can see there is a small distal emboli in this case, and the patient did very well. And 24-hour CT, you can see a bit of a ischemia, but relatively done very well. And that's just 72 hours. Difficult access, if you don't always have to use a balloon proximally. Here is a patient in an 87-year-old. As you can see, she has multiple infarcts, M1 occlusion, and it's a very difficult access. Although I always try balloon, here I wasn't able to get the balloon up, and you can see the arteries were looking not very good. I managed to get a large catheter here. I think this was a Neuromax that you get in, and you can see you can literally get it around, and then you have an M1 occlusion here. So my technique would be get a micro, so no distal access catheter, you get a one microcatheter here, and you find your way into another microcatheter across. You use a double stent reviewer, and one of the benefit of that is sometimes if once you put the two stents in, you can pull your catheter up also. So you can use the stent to kind of take your proximal sheath up. And then you can see here I had to exchange, and I have used a solitaire 6x40 and 4x40. And then you can see your first microcatheter here. And it's very important for not to remove the wire. I'm kind of saying it again, because first time when you start and you're not sure, you land up taking the wire out, and then you don't know that you keep going into the same branch. So you leave it here. Sometime I will leave the talker also at the bottom. I usually, once I unsheath both the microcatheters, I usually put a talker on them, so that you know you got a very good control when you're removing the stents down. So basically at the groin I'll have a talker on. And here you can see again, your two branches here, and you can see that you can get the whole thing out pretty much, and you got a good result. So you can do this in tandem lesions. Here is a case where you got a stenosis, and it was difficult. I angioplasted that, and then I wanted to get in, but I couldn't get in. But eventually what I did was I put a stent in, and then as you can see, you can put the stent, and once you got a stent in, you can then take your access catheter distally. And again, one of the things that you need to do is you can then put two stents, as you can see, one stent here, other microcatheters here. Very important to use a lateral view, then you know you are in two separate branches, and you can then aspirate, or under aspiration, balloon inflation, you can get the two stents, and you can take them out. Last, can I do a second? So a complication, wrong stent. If you do this, here is a left M1, and you can see again, you can't see distally, and ideally I should have put one here and one here, but basically didn't realize that, and then you put both the stents into the same branch, and that's why lateral is very useful. As you can see, when you pull it out, you know you have dissected this branch. Now don't go into this, because you're going to get into trouble. So I had recognized that I have damaged the vessel, and I did not get into it, and that patient didn't do very well. Thank you.
Thanks a lot, Tufail. So this was very interesting, from Ajit's wide bore catheter and no stent retriever to always two stent retrievers. So I have a couple of questions, Tufail. You mentioned 6x40 to 4x40 and 6x40. So any choice of stents here? I mean, how do you choose the size of the stent here?
So my go-to has always been the Trevo or solitaire. So, and I think, not sure whether there is big difference. Personally, I don't feel there is much difference. And also because I am a primary double stent person. So I just don't faff around trying to get an aspiration catheter. I've got a distal access catheter, two microcatheters, And because I do it as a first pass, as a first technique, primary technique of double stentectomy, then I usually will go with a 6 or a 4. And to be honest, it depends. If I have a striker people in, I'll use a treble. If I have a Medtronic people, I will use a Medtronic. Honestly, I don't feel there is a big difference between the solitaire and the treble. They both do a good job. So I just used any of them.
And of course, double stenting means MC and MC bifurcation. What about ICA occlusion? In that case, also you like to use 2 somehow? Or no?
I love ICA occlusion. If I have a T occlusion, I think double stentectomy as a primary technique for me, the success rate is very high.
But where do you place the 2 stents?
So if I can get into the A1, yes.
All right.
If I don't get into the A1, I try to get into the ACA. But you sometimes don't know what that A1 is like. So I'm usually very careful with an A1 not to go with a 6. I usually will put a 4 in the left in the A1 and MCA will go with a 6.
All right. That's pretty interesting. And any question from the audience is, there.
So I just wanted to know what percentage of both symptomatic and asymptomatic hemorrhage post double stent retrievers, and if it's not working, like how many passes do you make with the double stent retriever, and had you any cases with stent interaction, like both got intertwinkled inside the vessel while pulling it out?
With the symptomatic hemorrhage, I don't think I've seen any significant difference in terms of primary stent, single stent versus double stentectomy. We've analyzed recently our data because I have 3 colleagues and now we got 2. One of them, I use double stentectomy as a primary, my other colleague doesn't use double stentectomy at all. So it's a very randomized control between the 2 of us. There is no difference between in terms of symptomatic hemorrhage. I've not had entanglement. What was the other question?
So how many times you pass the double stent?
Yes. So success rate for me, and we have looked at that too, my success rate, primary success rate in double stentectomy has been significantly higher as first pass technique compared to my colleague. But it doesn't always work. So I have had failures too. But usually by the second time you've done it, your heart cannot take any more. And once you know that if your double stents are not working, you're probably not going to work. So my threshold to do a 3rd or a 4th is very low, because when I can't get double stents in and can't take the clot out, I find it that nothing works. So usually for many people is a last stage attempt. If I have done it twice and if your double stent doesn't work, what is going to work? So some of them are just going to fail. I don't know whether you have a similar experience.
So to fail, what we do is, again, we go by the volume of clot.
Sorry?
I go by the volume of the clot. So if I see the thing is, because it's MR, we actually see the clot much better. So if we got somebody from the M1 going to the M2, then we use a double stent retriever, but it's just limited to the M1. I really don't think that's an advantage. So we do the classical Solemnum most of the time, like I said. So we are very, unlike what people believe, for us the whole MR protocol is 10 minutes. We have an MR attached to the ER. It doesn't take much of a difference between CT and MR in our center.
Recently, sorry, Vincent?
No, I think
Vincent,
there is one very important point when achieving this technique, is that you put 2 microcatheter and you do not recross after opening the stent. I think it's important to say, because people may just say, I open one stent, then I take another micro and I'm crossing the first stent. So just to be said that it is increasing the risk of the procedure, since you have to work to cross the first mesh. So if you do this technique, it's 2 independent microcatheter, 1 in each branch, and then you deliver the 2 stent after, just to say that.
Yeah, that's a good point.
Yeah, and secondly, there is something interesting, is that the article you showed on Mark Ribot paper is an in vitro study. So meaning that in vitro, it's much more efficient to put 2 stents than 1 stent. And it has been confirmed also with Professor Maki in Geneva. He did the same independently, so it's much more efficient. But it doesn't take into account the potential endothelial damage that you may cause probably, in the patient, because it's a little bit more aggressive things. What they have shown to answer to you, is because what you are resolving into the double stent is the incertitude regarding the location of the clot in the M2 branch. We know that anatomically the angular artery is dominant in 60% to 70% of the case, and the clots tend to go in the inferior branch. And when you are doing properly the maximalist approach, normally you aim to go in the inferior branch, in the angular branch, because she's more likely to receive the clot. But this is not a systematic happening, so that means that it can go in the superior branch sometimes. So the double stent is reducing the hazards of not being in the major branch where the clot relies after the M1. So you are always grabbing the clot in these M2 segments. But in vitro, what is interesting, it is that it is increasing also the efficiency, even for a pure M1 clot, because of it is embedding completely the clot and disconnecting the clot from the vessel wall. So there's two effects, reducing the hazard of the M2 location of the clot. Secondly, decreasing the circumferential contact of the clot with the vessel wall. Now, we're speaking about money. I mean, it's a 6,000, 7,000 first-line procedure that requires more technicity. So again, my point is that stroke has to be a wide spread technology in India, in France, in small centers, not in big university centers only, in all the small centers if you want to cover the services. And this is for me introducing a level of technicity that is refraining us from having a very large first-line approach for stroke. So I think this is good in your center to fail in your hands. This is good in many centers, but it will not be in the future the first-line approach of thrombectomy.
Yeah, I agree with Vincent. That's why if you see in our talk, this comes under refractory clot category. I mean, we are not trying to say this should be the first approach. Okay, Tufail is doing it, very experienced, financial not issues, and maybe some Indian centers may also try it. But our attitude here in the meeting is to show these different approaches, and to us, it comes under the tough clot category. It's not coming out. Then one of the options, Vincent shows his option, and one of the options is double stent retriever. So since we are running quite late, Ajay, one comment, and when we go on to the next section.
So Dr. Tufail, for T occlusion, the clot might be just from the MCA to ICA, or it might be going into the ACA as well. So while trying going into the A1, you are not afraid of pushing the clot into A1, which was not there earlier. So as you said, like if it is a T occlusion, so in the first pass, do you go into both the branches, or you go just to the MCA, which is easier to go even with the two stents? Or you try to go into both?
No,
the first
preferably MCA, because ACA, going into ACA and pulling it, you are risking quite a lot. So on the CT, you can often see the clot from the T going into MCA, then often I will just put two. But if I know that I have, and if I don't put I'll go with a microcatheter, like Vincent said. Most important thing is to make sure you are not going through the stent. You have two microcatheters in two sides. And if I do get into the ACA, then I'll go with a very small stent into the ACA. So and what I've done sometime, I've used a 17 system on the ACA side. And often ACA, I will go for a 17 catheter.
Yeah, so, that's a great point actually, and thanks Ajay to brought it up. But okay,
I'll just add.
One comment, yeah.
Just one comment. I mean, wonderful discussion. I mean, as far as future aspiration, stent retrieval, I mean, just experience. I mean, last year we happened to do, thrombus metagenomics, and we isolated 27 bacteria. So one point I want to make, like Coagulase positive Steph, it was in, 8 refractory thrombus. I don't know, I mean, it's not that I can prove it, but, something is Coagulase positive residing in your thrombus, you need to probably, look for new avenues.
Yeah, absolutely. Even Vincent mentioned that in calcified clots and all, think about infective endocarditis. There's a lot more to learn about clots.
Yes.
I mean, this is just an overview. I mean, I think one of the issues with the program, I discussed in Rashma, is just too long. We should have kept more time for discussion, but we are here. We are trying to do the best which we can do in a day.